I think I got a thumbs up signal, so guess that means go ahead and get started. Welcome, everyone. My name is Robert Dreibelvis. I'm a professor at the London School of Hygiene and Tropical Medicine. We're going to talk today about climate change, hygiene, and health, particularly efforts that are kind of global efforts to identify really research priorities and a shared research agenda that can shape moving forward in this space. The session here, just to kind of give an introduction, we've got this divided into three broad sections. So in the first part, we're going to talk about some evidence reviews and some priorities moving forward. So these are some kind of direct work that we've been doing at the London School of Hygiene and Tropical Medicine as part of our kind of partnership with the Reckitt Global Hygiene Institute. The first, we'll be looking at kind of what evidence do we have linking climate change to hygiene and on to health outcomes. And finally, another part, we'll share the results of a big consultation program that was run by some of our speakers that'll come up here around kind of getting shared what are the research and learning priorities that are really needed for adaptation. During the second part of this, so our kind of second block here, we're going to hear some research projects that are really on this kind of climate, hygiene, and health nexus. So not just where are we going, but what are the things that are going on right now? How do we actually start incorporating climate change into our hygiene research? And then at the end, we'll kind of move on to a participatory panel. We'll have some guests bring up there. I'll introduce everyone as they come along into the session. Yeah, I thought there was. So just a little bit of background and kind of scene setting here. This all started in some earlier discussions. Actually, I've someone who does quite a bit of hygiene research. I started talking about climate change, and I got multiple people saying, "What does hygiene have to do with climate change? Like, we can't just hand wash our way out of climate change." But we do know that this is a problem. I'm not going to explain all of the varied challenges associated with climate change. But we do realize this is kind of a big, multi-complex, all-engrossing type of thing. Similarly with hygiene, I think if we went around this room and asked everyone to define hygiene, we would probably come up with the number of definitions equal to the number of people in the room. So we're dealing with already too complex that are very kind of lots of indirect, direct pathways. Boundaries and definitions can get quite blurry, and kind of navigating this space can be quite tricky. And then we integrated health into that. So how can we really kind of start navigating in this space? Now, this is kind of with a broader team. We started with a conceptual framework to kind of guide this. I'm not going to go through all of this because this was our initial attempt at this. And we immediately found that this was both way too simplistic in certain areas and way too elaborate in other areas given the state of the evidence. So the first part, we knew kind of quite quickly we needed to start updating how we were thinking about climate change to align it with kind of IPCC terminology and kind of bring that climate change discourse into some of the kind of standard research and hygiene that we're doing. We also were looking at these cascade effects. Spoiler alert, there's no evidence on any of these in any way, shape, form, or fashion. And we're going to talk about what evidence we actually have about some of these linkages. And finally, kind of reflecting that idea that hygiene itself can be such an amorphous, multi-dimensional aspect. We wanted to be a lot more concrete in what we were talking about. So moving forward, what we're really talking about when we discuss hygiene for the rest of this session is we're going to kind of refer to these three broad domains. First, we have personal hygiene. That kind of encompasses what we standard think about, things like hand washing with soap, but also face washing, menstrual hygiene, bathing, so anything about the individual and their ability to practice hygiene. Second, we have domestic hygiene, and a lot of these we did just for the sake of making this a manageable exercise, kind of focused on the domestic environment, but things about the domestic environment are readily transferable to a lot of institutional settings as well. Here we're talking about things like sanitation systems, keeping those clean, keeping those functioning, cleaning routines, even solid waste management, as well as kind of how hygiene relates to pest and vector management. And finally, we have food hygiene. So this is another area. I probably don't need to explain what food hygiene is to this group, but that's our other domain where we have here. So really looking at food hygiene from production to the consumption, so along that entire food value chain. So what we ended up with was our new refined, simpler conceptual framework that we're going to be kind of mapping a lot of our discussions along here today, are really kind of what are the links between these climate-related hazards and climate impact drivers through their kind of, the specific aspects of each of these. How do those impact one of these three dimensions of hygiene, and how does that relate onto health? So what we did, and we'll talk about these in a little bit, or other people more qualified than I will talk about this in a little bit more detail. We had two parallel processes that we were using. The first was an evidence mapping. So we went through as much of the literature as we could find. I think it was about 140 studies to really get at what do we know about these specific pathways? How can we map them from a climate driver to a health impact, to an actual health impact? And the second one was a forward-looking review. This was our evidence priorities, and this was defining our future research priorities. This was through a large-scale sector consultation. There was a survey that went out. Many of you might have even responded to this survey. We'll talk about all of those. And what these do is they've really provided some kind of complementary insights. The kind of what evidence do we have, and what is the evidence we need, and what are those two kind of speaking to each other now and in the future. And I realize this is a hybrid session, so you are welcome either in the room or in person. There'll be a lot of QR codes in this presentation, so have your phones ready. This will take you to a Mentimeter site where you're welcome to add in questions that we'll be reviewing as the session goes along for kind of input. If you're online, please kind of use that as well. And we'll use that. We're not sophisticated enough to switch back and forth between this and the Mentimeter site, but someone is monitoring it and we're reading it. So with that, I'm going to move to our first two speakers on climate change, hygiene, and health, evidence and priorities. So welcome Sarah Bick and Dr. Lauren de Mello Gayet from the London School of Hygiene and Tropical Medicine.
Good afternoon, everyone. I'm Sarah Bick, and I'm very excited to be here with you today to talk about our mapping review on climate-driven disruptions to hygiene. So this research aimed to understand what is currently known and critically what is evidenced about the links between climate, hygiene, and health. And what we know is that climate alters health risks. It shifts some of the pathogens, the habitats for pathogens, parasites, and vectors, and it creates greater risks at the household level, which necessitates practice of hygiene to a greater degree. We also know that climate, particularly extreme weather events, disrupts access to hygiene resources such as water and soap, and that these two effects kind of combine and interact in the changing climate, compounding effects on health at all levels. We know this is an urgent issue, that populations must strengthen their hygiene adaptations amid kind of growing instability in climates as well. So what we did is we aimed to systematically map the climate and hygiene and health pathways through a comprehensive evidence review to allow those sort of adaptation strategies to develop. So I'm going to kind of skip ahead to the results of this. So what we found through our systematic literature search was 150 studies looking at some of these links. These were published between 2000 and 2024, with most published in the last 10 years. And we identified in these studies 146 unique health outcomes, as well as 29 unique behavioural outcomes as well. And then among our 150 studies, we mapped out some of these links between specific climate exposures, the hygiene pathway that they were talking about, trying to understand how that was articulated, which is among those sort of personal, domestic, and food hygiene pathways, right through to those one of those 146 health outcomes. So among the health outcomes, we call these kind of links, and we found 612 links between climate, hygiene, and health. So lots of these studies were giving evidence on multiple links. And then we can, through mapping out these links, we can also kind of try and visualize the quantity of literature available, and which of these are most kind of prominent through these sort of Sankey diagram approaches, which I'm not sure if people are familiar with, but essentially the kind of width of connections between these different aspects of the pathway corresponds to the volume of evidence that there is on the topic. So when we did this, we mapped from our, I'm also going to try and go through a diagram that's very large and very far above my head, but we mapped the links from the climate hazards or climate impact drivers. There's our three categories of hygiene through to these 146 outcomes, which were too many to be listed on one page. And we can see that there are certain pathways that are quite well established, such as personal hygiene, this in the green category, which we have a lot of evidence about, and then some other pathways that are relatively understudied, such as through food hygiene and domestic hygiene. There were too many outcomes to think about, so we've sort of tried to categorize these into syndromes, such as diarrhea, which was the most frequently mentioned outcome, and respiratory illness, and then specific named pathogens that came up in these studies, such as Cryptosporidium, Salmonella, and Campylobacter. Some diseases such as cholera and dengue, and then a few studies gave evidence on biological and chemical pollutants as well. Okay, so now if we're breaking down our climate exposures into this kind of specific climate impact driver or specific climate hazard, we can kind of follow these pathways from the exposure through to the outcomes, and it gives us some more insights of what evidence is out there. For example, for personal hygiene, we can see there are quite a lot of links between precipitation and water scarcity through personal hygiene to health outcomes, as with reduced quantities of water being available, it makes it very difficult to practice hand hygiene, or potentially hand washing is deprioritized. With food hygiene in the pink, we can see that there are a lot of links with increased temperature, which may allow pathogens in food to proliferate. And that these are linked to both kind of syndromes like non-specific diarrhea, quite a few pathogens such as Salmonella, some diseases such as viral gastroenteritis, as well as some pollutants as well. And then for domestic hygiene, it's really these flood studies that look at how floods kind of washing through these communities bring a lot of harmful exposure to floodwaters, and they also create the habitats necessary for different vectors to thrive. So we might see disease outcomes such as leptospirosis. We can sort of further break this down by the nature of the evidence that we have. Not to make this diagram a little too complicated, I'll change the colours. But we have some studies that have produced qualitative analyses, and these are where we see a lot of our mental health outcomes related to sort of stress and anxiety and not being able to practice hand hygiene when there's water scarcity. In this sort of dark green, we have all the links that are tested for with statistical testing. And we see that it's sort of predominant among the personal hygiene-related pathways, and that we have a good quantity of evidence on some of these syndromes, particularly diarrhea, as well as some pathogens and some diseases. But there's also this large quantity of just purely theorized links here as well, which is also a lot of those kind of food hygiene pathways will fit in that in those categories as well. And you can see for pollutants, this is basically all theorized about pollutants in food. Okay, so we think that this research calls for more expanded research on some of these more understudied pathways. We saw that a lot of the evidence focused on personal hygiene and its relationship linking climate to health outcomes. There was a lot of strong documentation of infectious disease outcomes, particularly diarrhea, as we're probably very familiar with reading. But then these food hygiene and domestic hygiene pathways are really mainly theorized at this moment. And we know that it's very important to develop intervention strategies that can target those most vulnerable pathways. And to that end, we think that this framework provides the foundation for developing a future climate, hygiene, and health research agenda. And with that, I will hand over to Lauren de Mello Gayet, who's going to talk about that part. Thank you very much.
Gosh, it is really big, isn't it? Right, so kind of building on that work in these kind of two parallel processes, we have this kind of systematic mapping, the existing evidence, and then we conducted this kind of research roadmap, we're calling it, for climate adaptation. And so kind of comprehensively, we've looked at that evidence, saying what's existing out there and kind of what are the next steps in doing so. So we kind of conducted this expert consultation, which I think some of you in this room may have been part of, key informant interviews with climate scientists, public health scientists, hygiene specialists, to ask them what are their evidence needs, right? Evidence to inform their programs, to inform their implementation, to inform policy and practice. We then kind of use the Chinry methodology. I'm not going to go into the details, you can read about it later, and it kind of helps us review those questions, review those evidence gaps, and then start to rank and prioritize them, right? We are in a resource finite environment. We need to think about what research needs investment, and so this is a process and a methodology to do so. And we were really fortunate to engage a wonderful community in doing this process. So we had structured consultations with 141 global experts, so across countries and disciplines and contexts, to really inform what research is needed. And this is not specific to low or middle income countries, this is global research priorities to understand that climate change will be affecting all of us and in different ways. And so I'm going to kind of, before I dive into the questions and give you my kind of hot scoop on the questions, I want to talk about the types of research that was being required. So we break this down into, it's called the 4Ds framework, but it's about descriptive research, delivery research, kind of development research, and lastly, discovery, which is kind of more kind of new interventions. But actually, the status of our questions, this is the top 20 research questions that were prioritized by 141 global experts, asked for the descriptive research. So it's focusing on an emphasis that's highlighting our gaps in our understanding. Gaps in our understanding on the disease burdens we're going to be seeing, the behavioural determinants, the coping strategies, what's going on right now with different climate hazards, different climate impact drivers. We still are interested, so 20% of our research is still interested in delivery, so what are the current interventions we are doing? Like how are they working, how should they be, kind of what's working in different climate settings? And 5% of our research questions thinking about adaptations, right? So developing further iterations, kind of tweaks and changes that we want to be seeing. So it's really interesting for me initially to see, we want to understand what's happening now, the status quo. Our understanding is still something that is to be prioritised. So I've got another QR code for you. This is a link to the top 20 research priorities. It's linked to a PDF document. It will be kind of released more widely later. It'd be great for you to read this kind of in your own time because it's a list of 20 questions. And rather than you listen to me read those 20 questions, I'm going to give you a bit of an overview kind of through the rest of the presentation. But then you have them when you want to read them on your way home or on your coffee break later today or tomorrow. But we're kind of coming back to this descriptive research. So that was the majority of our question fit into this category. And we want to characterise kind of how different climate hazards, climate impact drivers are affecting hygiene-related disease dynamics, the behavioural determinants, the coping strategies that we're seeing by populations, how they might be deprioritised in water or hygiene in different instances. And I guess that comes across with personal hygiene, domestic hygiene, food hygiene similarly. We want to understand what the kind of effect of extreme weather events is on infrastructure disruptions and what that relates to. How is it compromising hygiene infrastructure, our supply chains, and creating new kind of exposure or contamination pathways? And there's a focus across the kind of top 20 questions on vulnerability. So we really want to understand and research that examines kind of the hygiene challenges faced by vulnerable groups, people with disabilities, women and girls across climate emergencies especially. They're going to be particular hygiene needs that we need to be accounting for in kind of our kind of adaptation strategies. So when it came to our delivery research, we want to think about the promotion and communication of hygiene during and pre and during and post extreme weather events. We also need to be thinking about how we now communicate hygiene promotion, hygiene strategies in heat waves and extreme temperatures. These are potentially new strategies that have to be developed or kind of iterated upon. Again, we need to be thinking about what intervention strategies are needing to be tailored. How can we provide tailored support for vulnerable groups across different settings and what that looks like? And this will involve research that is potentially piloting or testing on these adaptations to see what will be beneficial in different circumstances. And lastly, it's thinking about this adaptation, right? So we have this incredible plethora of hygiene interventions, right? We have portfolios of hygiene interventions across organisations and institutions that we have in our arsenal. But what do we now need to adapt those somewhat effective and evidence-based interventions for different scenarios? So water scarce or drought-prone settings, or kind of thinking about how do we make climate-resilient hygiene infrastructure or systems in place. So we can see these kind of direct series of change that we need to evidence basically to support what we're doing on the ground. Now I wanted to also pivot the research questions thinking about how they lean towards different climate hazards. And what you'll see when you read your long list of 20 questions in your coffee break is that there is kind of an overemphasis, well, more of overemphasis, but an emphasis on acute hazards. People are thinking about extreme weather events. And I think most of us do when it comes to climate change. We kind of go for this, it's disaster-based only. So yes, there is the predominant kind of evidence need in that sector, but this was focusing on floods and the kind of cyclones and the cascading effects on our infrastructure and how that changes hygiene. But we still need this emphasis on slow onset events, so climate impact drivers such as reduced rainfall or water availability, and how that will change the water available and how that will have a knock-on effect on the hygiene that you practice. And understanding that real kind of behavioural root and what's happening in the household is really important. And secondly, thinking about heat and humidity, right? We're seeing this increased risk in food, we're seeing this increased risk in exposure, and we need to understand how pathogen dynamics are changing across our water, across our food, and across our domestic environment. So when we were doing these two kind of parallel processes, we can see that climate and health obviously is on everyone's mind, it's the theme of this conference, but we found that hygiene was underrepresented in many of these climate health agendas. So here we've decided to put forward these kind of actionable research priorities to help us build the evidence base, to move hygiene further up that agenda, and say here we've got some evidence that could support adaptations that are needed. There is a prioritisation, as you've seen, in descriptive research. We want to understand there's an urgent need for empirical data now on our disease kind of burdens, our pathways, the kind of behavioural determinants and even the behavioural outcomes that we might be seeing and how the people are going to be changing their behaviour under climate conditions. We've got a really strong focus on equity, highlighting that there are going to be particular challenges or particular needs for women, girls and people with disabilities that we need to understand now thinking about adaptation. And lastly, we do have an emphasis on acute hazards across those questions, so that was the priority for now, but we have to remember that these slow onset events, slow onset climate impacts, are still happening. And so research is needed to think about these longer term adaptation strategies. So it's kind of highlighting where we are right now. And the thing is, research changes, right? So the idea is that we fulfill all these research gaps and we kind of get the evidence going, and then we kind of think about what other research is therefore needed in future strategies. So bringing us back to this slide, we've got this mapping, our kind of evidence mapping that systematically told us where the existing literature is and kind of what's been theorized, what's been tested, what still needs to be explored. And then we've got this globally kind of expert inputted consensus list of research priorities saying this is where we'd like to invest, this is what we need, kind of the sector saying we need this to help us support our programs, to kind of have this descriptive studies, this focus on equity, this focus on kind of climate-driven hygiene challenges. And so we're pulling together in kind of both like directions to say where can we go and where can we provide more evidence. But what I want to add is one caveat here, is that the evidence that we have identified, or the evidence gaps, they might not necessarily just be that we need to produce new kind of studies completely, is that there might be a lack of synthesis of the evidence that we do have. And it's kind of now thinking about how we can kind of arm ourselves with that, to kind of pull it all together in one place, that therefore we're kind of underscoring our kind of existing studies that have happened, pulling them together in one place, sharing those, whilst contributing to kind of the literature that is required at the same time. And so kind of balancing the kind of two methodologies or two different ways of thinking to make sure that we're doing this all in one place. So I think that's me done, and I'm going to hand over to some run-through examples in our next presentations. Thank you very much.
Cool. Thank you, Lauren. And we are 3 minutes ahead of schedule. So if there are any questions, we can go ahead and take one or two. But if people are thinking about those, you can also use the QR code and put that online as well. But I'm going to go ahead and invite our next speakers. We're going to hear about 3 research projects. One from Professor Katrina Charles of Oxford University, discussing measuring climate-resilient wash services. A nice link to some forthcoming events tomorrow that are going to be talking about our new indicators around climate-resilient wash services. We'll have Professor Peter Lloyd Sherlock discussing climate change and hygiene for older people with disabilities, based on work that's ongoing in Brazil, trying to understand the vulnerability within this specific population. And then finally, we'll have Dr. Om Prasad Gautam from WaterAid discussing some recent research on climate-resilient wash and hygiene interventions in healthcare facilities across 3 countries in sub-Saharan Africa. 2 in sub-Saharan Africa, 1 in Nepal. Right? Sorry, it's really tiny print down here, so apologies for that. So with that, I'll go ahead and hand over to Katrina.
Thank you. Thanks very much. And it was really great to have those presentations and to learn more about what's happened post those consultation stage as well, and to get understanding of all that work, and to get a better understanding of the range of research that's going on in the area. What I wanted to focus on was particularly around understanding methods to answer some of these research questions. We think about how we interpret what's there, and then how we respond to these research questions. So I've been doing research around linked to climate change for around 15 years now. So, you know, have some lessons from the field. But firstly, what I wanted to come to is, so I'm a drinking water quality person, but I'm here talking about hygiene. So I thought I'd just spend a moment on highlighting those links. So when we think about drinking water, we often measure it either at, is this going to work? Oh, no, that's not what I want. On the bottle in the middle, that's looking at point of use. So we measure it at the household. So for example, in the picture you see someone filling up a cup as to drink from tap. So that's the way we're thinking about point of use. It's what you drink. And so it includes hygiene issues associated with the cup. So cleaning of the cup and cleaning of fingers. The point of collection is the other one we often hear about. So that's collecting it from the tap. So where someone would go and fill a jerry can from, for example. What we often miss is that that's also including local hygiene issues. I don't think this fits into your 3 categories very well at all. So this is often from hands, but can be from animals as well. So if someone has touched the tap, if it's not cleaned, that water is also dirty. And then you can go further back into the environment. You've got the infrastructure and the environmental hazards as well. But if we look at the contribution of hygiene at those particular sites, we have these 2 diagrams. So on this side, we have that showing the proportion of point-of-use samples that were contaminated with E. coli when they were collected from the tap, like in that photo. And so there's no storage, there's no household issues. And that water was otherwise not contaminated if you sampled it with a bottle rather than through the tap. So we can see, we have this data for all the mixed studies that have been done, so 26 odd countries, and these are just showing some of the high-end ones, but it ranges from about 10% to about 70% of contamination of those point-of-view samples are contaminated from just that cup, basically, and from that collection process. And then on this side, the green section at the point of delivery is showing you that about half of the samples that you would collect at point of collection would be safe if you actually clean the tap. So there's a huge contribution of hygiene to water quality as well. But some of the work we're doing now is working with Barbara Evans, working with WHO and others who are listed here to look at, can we develop national indicators for monitoring climate resilient wash? So I'm not going to go into this framework in detail. It's very complex. You can find it on the website. It's all freely available. And there is a session tomorrow that will tell you more. But part of this has been systematic review. So very much like Lauren and Sarah have been doing in the team, it's trying to understand what's the evidence we have. And where we differ slightly in this is what we were looking for is evidence linking attributes and actions, to outcomes in WASH that are related to climate resilience. So missing some of that descriptive research, but trying to understand what's the difference. And we didn't find much. So some of these ones, so for hygiene, for example, we started with over 5,000 papers down to 28 papers were included. So that's how little evidence there is. Similar story with sanitation, water. People have been doing a lot more on climate, so it was an umbrella review, and we ended up with 109 papers in that. So it's a bit different. But we see this big gap in the data that's available to help us make better decisions on climate change and climate resilience. So what I wanted to do is to just quickly talk about 3 things that I think are important to how we understand behaviour and experiences during extreme events. And so Lauren's already highlighted that extreme events has come out as a focus point. We know behaviour is going to be really important for thinking about hygiene, of course. And so I've got 3 points from some of my research. So firstly is thinking about how we collect data. If you want to collect data on an extreme event, you can't plan for it. You know, they're getting more common, but generally, you're looking at, you largely want continuous data to be able to pick out what changes during an extreme event. This is an example from Tanzania. So you just about see the coloured sections, the R ones. So those are different rounds. So we tried to have regular data collection across different seasons, but we didn't get all the extreme events. We know that. We get some, but it's very difficult to design a study to look at when you do it. That also becomes an issue for recall periods. If you want to ask someone something about their behaviour and understand what they're doing in terms of hygiene, you can't ask about what you did 6 months ago. That's not something that people will remember well. It needs to be quite current. So it's really difficult to get good data understanding how behaviour changes during extreme events. You also have to be really conscious of researcher safety, because you don't want researchers actually going out in a lot of these conditions, which makes it difficult, and people are under a lot of stress as well. The second part is about interpreting data in variable climates. So this study was in work we did in Kenya, where we were trying to understand, like we planned it to be seasonal, so we could get some of this variability. So we went what was nominally the hot and wet in the red, and the blue is the hot and dry. So what we found was that water security was higher in the hot and dry season, which was perhaps a bit unexpected. So this was where it was really helpful to have, this way to understand that part of the issues with climate change is the seasons and the conditions are changing. So what you expect isn't necessarily what you find. So having climate scientists understanding what the actual weather is, not just relying on seasons, becomes quite important. So this, there was other things going on that meant there's actually much more water availability during the dry season. And then thirdly, thinking about how we compare results across contexts. We really need to move from case study research up to something that's comparable and we can work across different countries, and that's something we find that's quite missing in the data currently. If you're thinking about climate events, it's really got to really be thinking, we can't just compare a flood and a flood. They can be very different. Is it a regular flood? Is it an extreme flood? And equally for seasonal things, is it something that changes because of a threshold? Is it something that's people are going to get used to? Is it something, what is the relationship between the outcome we're interested in terms of behaviour, and that what is the outcome we're interested in, and is it changing because of behaviour changing because of the climate, or is it changing because of the environment changing? So these are two examples. This is Bangladesh and Tanzania of research we were doing at two sites, and just highlighting the difference on the y-axis in terms of the amount of rainfall we're seeing at different sites. So something that might be a very big rainfall event for Tanzania doesn't even rate for Bangladesh. So how are we going to compare what an extreme event means across those different sites? So those were the 3 points. I think a little bit from our research, whereas Lauren's highlighted there's a lack of synthesis rather than an absence of evidence. What we've also seen is a lack of action, in what evidence for what actions we should be taking. And I do think, to a certain extent, this gap in the literature is coming because we've just written off climate as a bit too difficult at times, there's a lot of work that was done in WASH that does mention the seasons, but that gets glossed over very easily. And it's a bit like we have invisible women. So a lot of medical research just ignored women because we're too complex. But whereas equally climate has just been left out of too much of WASH because it's too complex to also measure the weather. I think the final point on this is just a plea to include climate scientists in any work you're doing related to climate, so that you have someone who can explain the complexity of that side of stuff to you. Don't expect to be an expert in everything. So finally, I have no idea how I done time, but thank you. And this is the session tomorrow where our colleagues at WHO and UTS are sharing more on the global and national indicators for monitoring climate resilient WASH. Thank you.
Hello everybody, good afternoon. My name's Peter Lloyd-Sherlock and I work on the health of older people. Firstly, I'm very, very grateful to Robert for inviting me to come along to speak in this panel. I may be the only person working on older people's health who you're likely to meet at this conference, or perhaps any other conference relating to water and WASH and issues like that. And in fact, relating to that, how does this work? I was very interested when Lauren presented the... Oh, there we go. Right. I was very interested when Lauren presented those 20 priorities for climate change and hygiene research, that absolutely none of them made any reference specifically to older people, perhaps people over the age of 60, people over the age of 70, although I did notice that two do refer to people with disabilities and their personal hygiene, quite rightly, as very important issues. Now, perhaps not surprisingly, the point I will make is that, of course, later life and disability are very strongly associated. So the probability of having an impairment or a disability, however you define that, is very strongly associated with old age and as you move through old age to very old ages. So these are data from the United Kingdom, but you see very similar relationships in low and middle income countries. If anything, that curve of increasing disability through later life is even sharper. And there are a lot of old people. Currently, the population aged over 60 is about 1 billion. By 2050, so in just a generation, it will double to 2 billion. So you've been looking at some meta trends in terms of climate change. Well, here's another big trend taking place at the same time, population aging. The majority of older people are already in low and middle income countries, and the proportion will increase over time. So clearly, there are a lot of people at older ages in the global south, and a lot of those people have disabilities of one kind or another, possibly because they have them right through their lives, or particularly in later life because they develop them as they age. So I would like to think that when people talk about people with disabilities, sometimes you see perhaps NGOs, and when people talk about global health and international development, they seem to regard older people and people with disabilities as two distinct groups, which I do find rather strange. Lots of older people with disabilities, and reflecting that, very, very bravely, the Reckitt Global Hygiene Institute gave us a little bit of money to do some exploratory research around hygiene and older people with disabilities living in poor slum districts in different parts of Brazil. And so the first thing we did, you're seeing a few of these this afternoon, aren't you? We did a systematic review because there hadn't been a systematic review, simply trying to gather what was already known about hygiene, personal hygiene in later life, be it in high-income countries, lower middle-income countries, be it related to climate change and hygiene and health effects, or just hygiene and later life in general, referring to behaviours, interventions and issues. And I know this is sounding a little bit sort of repetitive, but guess what? We didn't find very much. But what's also very interesting is that we found 29 studies on oral hygiene. Oral hygiene in later life is quite an important issue, but it would seem that there are quite a few dentistry journals out there that seem to be doing quite a lot of work on that issue. We only found 3 papers looking at menstrual hygiene in later life, and only 3 studies looking at body hygiene, bathing, which we define in a very broad sense in later life. 2 in the UK, 1 in the USA. So that's about how often people are able to bathe, the sorts of challenges they may confront in terms of maintaining body hygiene or interventions, assistive technology, whatever it might be to facilitate that. And if any of you think about the sorts of issues that older people confront when trying to maintain body hygiene, 3 studies, that's it. So it's an incredible gap in knowledge, to put it mildly. One of the reasons, I would say one of the reasons, is that people just aren't very interested in the issue. But another reason why we don't have a lot of published research about older people and body hygiene and bathing is it's quite difficult to talk to people about it. You can't just get your clipboard and go door knocking and ask people how often they manage to get a wash, a body wash or a shower or whatever it might be. And this was a focus group we did a couple of months ago with some community health workers, and I think it really gives you a sense of issues in terms of stigma and shame when people are talking about personal hygiene issues, especially perhaps people who did not have personal hygiene issues at earlier stages in their life and felt a lot of positive self-identity, who are now struggling to maintain what they consider to be a respectable, reasonable level of personal hygiene. So community health workers saying that the family always give them a wash before we come, so no way of knowing what's really happening. People claiming they have a bath every day, but the evidence being very clear that that is not the case. Or even not wanting to admit that they haven't had a bath recently because they're concerned that somebody will then coerce them into having a bath or a shower. And often people are afraid of doing so because bathrooms, particularly for older people with impaired mobility, are very high-risk environments. And at the moment, we're trying to do some data collection, looking at frequency of bathing, and I think we're going to confront all of these sorts of issues, and we're trying to resolve those as I speak. But what we've realised is that probably more than simply looking at behaviours and how frequently people are able to wash and maintain hygiene. And believe me, in our qualitative research, I've seen some older people who haven't been able to have a proper wash for several months. It's more useful to look at the facilitators and the obstructors. And they can occur in various ways. And of course, one is that the kinds of housing, the kinds of facilities that people have in the neighbourhoods we're working in are not very friendly to people with disabilities, to put it mildly. So this is a fairly typical photograph that we took a few weeks ago in one household where we were doing some interviews. So you can see the stairs coming up into the bathing area, the very narrow doorway. So in this case, the person was a wheelchair user. There's absolutely no way they can get into there. They were also obese. Obesity is becoming increasingly prevalent in later life. And of course, if you need somebody to assist you with bathing, that becomes a very serious issue as well. So we're in the process. We're only about a third of the way through our study at the moment, but we're in the process of collecting data. But of course, while you're collecting data, particularly the qualitative data, you're starting to think about it and process it a bit. And we've identified 4 broad kinds of facilitators or barriers to hygiene in later life. Some of them are intrinsic characteristics of the individual. Some of them relate to what we just saw in those photographs in terms of the environment you inhabit. Environment here, less so talking about climate change, although climate change, of course, what it does do is increase the need for more frequent bathing. Access to care, somebody to help you bathe if you need it. And motivation can be a critical factor. So people who are isolated, who are depressed, or are afraid because a significant proportion of falls occur when people are trying to bathe. So we have to recognise that as well. I'll skip this slide. I'm going to focus on just one other issue, and I've heard a certain amount about menstrual hygiene today. I've not heard anything about continency. There is no research at all about the prevalence, how common incontinency, be that urinary or fecal incontinency, is among older people in any country in the global south. No work at all. There's some work about continency as a reproductive health issue after people have had a number of births, so postpartum incontinency, but not in later life. This is a picture I took in a chemist, a pharmacy, in a poor neighbourhood. It's fairly typical. And the evidence suggests that it must be quite prevalent, but people are selling a lot of incontinency pads for adults, primarily for older people. So it would seem to be going on. I was doing a focus group the other day, and I was told in this particular city in Salvador in the northeast of Brazil, well, don't worry, we've got a policy which means that we provide 100 free incontinence pads to older people who need them every month. So there's no issue here. We're actually ahead of the game. I then dug a little bit deeper into how these people are able to access these products. Well, they need to go to their local health centre. Now, imagine an older person who's got mobility issues, who may have dementia, who may have all other kinds of impairments. That's what, a typical street inside these neighbourhoods looks like. So they've got to navigate that. They've got to get to the health post. They've got to go to the health post because they've got to be evaluated, assessed. They cannot be assessed by a community health worker or by a nurse. It has to be by a doctor. There are very few doctors. Doctors almost never make home visits. So you've got to, why nurses can't do this is beyond me. So you've got to be diagnosed, effectively, as being incontinent by a doctor. You get your letter, and then you have to go to the city centre, to their municipal offices, and with various other bits of documentation to show you're poor and this and that. And then if they feel that your documentation is in order, they will, several months later, give you access to those 100 incontinence pads that you can pick up from the local health centre once a month. If you're unable to get the 2 buses, in this case, to go to the centre of town, taking about an hour, you can send somebody else on your behalf, but they have to be your legally recognised representative. So you have to have had some kind of legal process to enable that. Yeah, of course. So none of that goes on. These are some data from one of the neighbourhoods we're working in, where we've been asking older people about continency. So this isn't a prevalence study. It's based on older people with disabilities in poor neighbourhoods who are part of a care intervention, which is part of a separate project I'm running. And we just asked whether they needed to use continence pads or not. So that's very subjective, but we could see that over half of the people in our study needed to use them. So this is not an unusual problem. I think we can at least say that. What's really interesting to me is only nearly half of them had been diagnosed, as it were, by a doctor, had got that magic letter, which then was the first step on the odyssey which might eventually enable them to access these pads. These pads are expensive. And I've come across with our qualitative work, families who have to make very difficult choices between accessing incontinence pads and other essential items, including food. Often people just don't bother, and so, believe me, that has quite a big impact on the hygiene of the home environment, because people just don't change pads or don't use them at all, and you can imagine the consequences. So, there you go. I'm the guy who talks about old people's health and hygiene. I hope you found it interesting. It's probably slightly different. I think it is a priority issue. I said nothing about climate. We know that during heat spikes and other climate disasters, a very high proportion of deaths occur among older people. And I think one of the reasons why they occur, although I don't have data to support that, is because they're already facing major issues in terms of urinary tract infection and other kinds of kidney problems, etc., because of poor hygiene. And then along comes the climate shock and things that tips it over the edge into catastrophe. Thank you very much. And please ask me lots of questions.
Good afternoon, everyone. My name is Dr. Om Gautam. I work for WaterAid in an international program department as hygiene lead. So in my presentation, what I'm going to share is how WaterAid modeling climate resilient WAS facilities and also hygiene behavior change intervention in healthcare settings. Primarily, our learning from 3 countries, from Asia and Nepal, and also East Africa and Southern Africa region, primarily Tanzania and Madagascar. This will demonstrate how operational organization or technical organization like WaterAid actually model the program and demonstrate some of the evidence that informs future programming and policy agenda. Since this particular research was done and modeling was done in healthcare settings, I just would like to set a context why modeling climate resilient WAS and hygiene behavior change in healthcare settings specifically is important. I just would like to trigger your interest. In every 2 seconds, a mother gives a birth to a baby in a clinic where there is no water, sanitation, hygiene. You can just imagine a health workers touching a newborn baby without washing hands immediately after birth. What happens? That leads for sepsis, contribute to neonatal death. Imagine a mother who just gave a birth, not having a clean water, and using contaminated water to clean. What happens? Hospital-acquired infection. We know 50% of the hospital-acquired infections are resistant to antibiotics. And by putting climate-resilient WAS services and hygiene behaviors, we can reduce them by 50 to 70%. I don't need to tell you as a practitioners here in the room. On the other hand, the extreme climate event are contributing the disease prevalence. There is a huge pressure in the healthcare facilities. At the same time, not having these facilities meaning compromising the quality of care, the burden, and then compromise all sort of health-related consequences to the clients. But at the same time, positively, many countries, the health ministries, are developing a WAS and healthcare facility standards. But when they are developing any standards, they have to operationalize their standards on the ground. So you cannot just standardize climate-resilient WAS without doing more rigorously tested intervention in place. What we have done, we had a good opportunity to receive a fund from JICA for 3 countries, Nepal, Madagascar, and Tanzania. What we have done, we wanted to operationalize climate-resilient WAS in 45 healthcare settings in 3 countries, targeting to those clients and primarily healthcare facility staffs, and assess the effectiveness of those interventions, the WAS facilities and behavior change intervention to looking the behavioral outcomes. So what we have done initially for this particular project, before baseline, we have standardized the climate-resilient WAS facilities in the healthcare settings. We wanted to see, with the standardization of WAS facilities, what proportion of healthcare staffs can practice the behavior. After that, we have done the baseline. After baseline, we have a cooling period, just didn't want to measure the reactive behaviors. After baseline, then we have implemented a comprehensive behavior change intervention over a period of 6 months, then did the end line. Throughout this period, we wanted to see whether climate-resilient WAS facilities are functioning and the health workers are actually sustaining those behaviors. Because this was a new initiative for these 3 countries, we wanted to operationalize those WAS in healthcare facility standards. Therefore, we have applied the behavior center design approach. It has 5 steps. Initially, what we have done, we have assessed the existing condition of the WAS infrastructure. We have also assessed the behavioral determinants, and also assessed the climate-related threats, potential hazards, assess the feasibility, because it is important that if you are designing any behavior change intervention, hygiene intervention, we have to include climate-related understanding and an assessment part of that process so that it informs the resilient programming. Then we have gone through a creative process to design a comprehensive behavior change intervention using a multidisciplinary team. In the team, we have creative agencies, the government, and also the climate experts into the room to design the intervention. This particular program was delivered through the trained health workers themselves. We really wanted to make sure that we strengthen system during the design and delivery. We train the health workers, and they themselves deliver this behavior change intervention in all across 45 health institutions. So what have we done? At the beginning, after the creative process, once we identify what are the technological solutions, climate resilient technological solutions, we have standardized WAS facilities. For water, we have diversified the WAS sources, water source, including the rainwater harvesting. We have elevated tank. The treatment unit was, water treatment unit was installed in different locations in healthcare facilities. We have also installed the gender separated inclusive toilet with raised platform, seal pit. We have also installed group hand washing facility closer to the toilet, at the entrance, at each point of care, and also the waste segregation into the healthcare facility, including its transport, and also establish the incinerator to dispose them properly. So these are prerequisites for behavior change. You cannot assess the behavioral outcomes without having this precondition in the healthcare facility. We wanted to, after this, we only did the baseline all across 45 health institutions just to see. After baseline, then we have implemented a very comprehensive hygiene behavior change intervention. So we have targeted 6 behavior, where hand washing with soap was the primary behavior. As Robert was mentioning, of course, we divide behavior in different categories. Of course, for this particular study, we have the hand washing with soap as primary behavior, clean use of toilet, safe use of water, waste management, and menstrual health and hygiene. We have we know that the exposing with the hygiene intervention with 1 time, 2 times is not going to be enough. So therefore, we have designed the campaign to expose them 6 times at least with 6 behaviors, reinforced behavior. We have standardized the package. We are going beyond traditional way of designing behavior change campaign. No posters, no leaflets, more exciting and emotional activities. Some of the activities includes for example, we have used 3 levers for behavior change. 1, emotionally triggering people interest to different emotional activities, including health workers' life game, letter exchange, emotional demonstrations, drama, transient work. Second elements was all about installing behavioral nudges and cues in specific locations. For example, to prompt the behavior, footprints coming from all the way from toilet to the hand washing stations, finger pointing stickers, cleaning rota in the healthcare settings, and also some of the activities that lead for social desirability, competitions among health workers to be a clean health workers of the month, intra-cluster competition between different health institutions. You can see some of those activities, behavioral nudges that we have put in place into the specific locations. This particular study has multiple behaviors, and we have assessed the knowledge, reported behavior, social norms, observed behavior. Because of time, I just would like to highlight the primary outcome of this study, which was a hand washing with soap at different critical moments in all 3 countries. The result shows that, if you look at the results, I'm not sure whether I will have the pointer. Oh, sorry. Looks like pointer is not working. Oh, sorry. You don't have the pointer. How do I go back? Oh, yes. Okay, so if you look at the results, the baseline, look the blue bar, provided all the preconditions were there. Hand washing with soap facilities, soap, water, water supply system, all hand washing facilities were functioning. Look at the hand washing with soap before touching patient, 10% in Nepal, I think around 54%, 20% in Tanzania, around 50% in Madagascar, for example. So what does it tell? Even if you have a climate resilient wash facilities, is a foundational, is fundamental, but it doesn't mean that the health workers will actually practice hand washing all the time. So what we have done after then, once we have implemented the comprehensive intervention together with the functionality of these facilities, the proportion of hand washing facility across different critical moments observed behavior were improved significantly, but there was a variations all across multiple critical moments. If you look at the after PPE, maybe after touching the clients, after touching body fluids, but of course all across there was an improvement, but there was a variations in terms of the behavioral outcomes. The study has a significant effect in terms of changing the behavior, but there was a variation in terms of the critical moments, which critical moments they practice the behavior. So what are we actually concluding from this particular operational study? I would say, I think this was applied research, more operational research, just to assess the feasibility and the creating a proof of concept intervention. What are we actually concluding is the resilient wash services act as a precondition to facilitate the behavior. So installation of this resilient facility will actually act as a precondition, but is not enough. So we should be definitely having these facilities with operation and maintenance plan in place in order to facilitate the behavioral outcomes. The participatory creative process helps designing more participatory creative process with evidence-based formative research. I think it has to be more climate sensitive. If we are designing any behavior change intervention, it has to be climate sensitive formative research. It is going to be quite instrumental in terms of designing context relevant behavior change campaign and also the resilient wash facilities. Then in this particular study, we have also looked the rates, more than 80%, the frequency of exposures around 6, and then the fatality, the consistent delivery of the intervention as designed. We have monitored the fatality through the thorough monitoring all across 3 countries. There was a high level of fatality across 3 countries. So that means we need to ensure the high level of frequency, exposures, and fatality if we want to ensure the behavioral outcomes. And finally, the comprehensive intervention. If you are thinking of changing behaviors in settings like healthcare facility, so we need to have promotional activities with nudge and precondition together with high level of rates and frequency of exposures. And that way, because this particular study was to demonstrate proof of concept, because the evidences shows that the behavior were changed, we can consider as a proof of concept now. So as a proof of concept intervention, what we have done together, because it was funded by JICA and implemented by ministry, all 3 countries, so we have developed a handbook in all across three countries. And these are considered as a proof of concept for government to replicate in other settings. And we had a session, for similar session on Sunday morning, and you have also heard at that time that this has been now replicated multiple healthcare settings in Tanzania, and Nepal and Madagascar, and government is actually taking it further into this. The reason that we wanted to include this particular study here, because organization like WaterAid or any operating organization or government, when we deliver any behavior change intervention or hygiene intervention, we have an opportunity to assess the effectiveness of this intervention implementing operational study. We call them applied studies together with that, so that it will show whether intervention can work, or it can also be resilient enough to ensure the sustained results over time. And if these are successful, we can confidently say the government to replicate this model in other settings. So we can contribute, as Lauren was highlighting, 20 key research questions. I'm sure in future, with the multiple opportunities for any operating organization on the ground, can leverage those programs to address some of the research gap identified through the intervention. Thank you very much.
From the University of Leeds, Joanna Estevez Mills, from consultant with the Global Health Division at the World Health Organization, and More Blessings Chidawase. I'm sorry if I'm, yeah, sorry. My last name's Dribelbis, so I'm very used to it being mispronounced, so apologies in advance, from WaterAid's Pan-Africa program.
Should we swap?
Yeah, maybe go over here. That would work better.
Smooth as silk. I think these are working, right? So we could sort of loiter around these. Oh.
Sorry. I went insane on this thing.
Dribelbus has a wardrobe malfunction.
Right.
great use of time. Thank you. Okay, thank you very much. So I'm going to start with you, Barbara.
Yes.
And I know, kind of as Katrina mentioned, there has been quite a bit of work and ongoing work on climate resilience, how that relates to water, sanitation, and hygiene. And you have done quite a bit of work on sanitation and its links with climate change as well. Could you tell us a little bit, or kind of what you think are the parallels that we could learn from that process of kind of understanding the links between climate change and sanitation and health outcomes? And what can we learn in the hygiene sector? What can we adapt from that program?
Yeah, super. Thanks so much. Also, brilliant presentations. I loved all of that. It was great. And I'm never going to forget old people again. So, I mean, first of all, just to say that what we found when we went through the review process, lots of parallels. I mean, as Katrina said, limited studies, different breakdowns, but a lot of research clusters around things you can do more easily than other things. So what we find in the sanitation sector is there's quite a lot of studies that look at, individual toilets, but very few that look at the effect on the whole reticulated system. And I'm sure the same thing would be true in the hygiene space. Research is going to fall into things which are easy to measure. And then if you layer climate on that, I think, again, just to really reiterate a point that several people made, catastrophic results are the easiest to see. They're not so easy to research, actually, because you're not there when they happen. Slow onset events are hard to see and hard to detect. And very often, actually, there's loads of studies that get reported, which probably we could pick out those slow onset climate effects, but nobody's recorded the weather data, so it's very difficult. You can go back sometimes and overlay historical weather data and try and investigate that. Similar clustering of like health hazards, in sanitation we love a flood. We always forget that, temperatures change processes, dry conditions make sanitation systems fail, but, we all love a good flood. And then two things that really resonate with me from the work that you guys have done. One is there's so much theory. I honestly, we read 1,000 theoretical papers. We can assume that if this happens, this would happen. So my favorite example, and please don't kill me for saying this, but I don't ever want to read another paper. I'm a journal editor as well. Please do not send me another paper that says, I think that a raised latrine will be climate resilient. A, I don't think that. But B, if you want to tell me that, you need to show me that it's true. This sort of theoretical thing is really problematic. So even in sanitation, I think we need this descriptive work. Perhaps one thing I would say that we do see in the sanitation research, which might be useful, is to work out, and I think you've started on it, but I think working out what are useful ways of chopping your hygiene question so that you can focus research. And I wonder if, when we're thinking about climate effects, what we might want to think about whether there's different ways of clustering aspects of hygiene. So, I think the supply chains question is really interesting, but in sanitation, we've done a lot of work trying to think, how do you look at the effects of climate on fecal sludge management? And it's something to do with roads, but, we don't really know how to get engaged in that disruptive research on how those are disrupted, and the same thing's true for supply chains. So I think there's lots of chances to collaborate, and I think there's lots of similar problems. I'm not sure we're really very far ahead. Is that bad?
I mean, it is. Okay, well, kind of go over to you, Joe. So I know with the World Health Organization, there's been a lot of work recently coming on the back of the pandemic, forthcoming guidelines on hand hygiene in community settings. So maybe you could talk a little bit about what is the role of climate change and how's that being integrated into WHO's hygiene activities and programs right now?
Sure, yeah.
I think you have to stand there.
Hi, everyone. Yeah, I'm Jo. I work in WHO Geneva in the WASH unit, leading on the hygiene work. And as you probably know, WHO holds the mandate to provide global guidance to member states where there's demand for that guidance. And I'm conscious here that I'm talking probably to quite a few researchers, and the focus has been on research, as it should be for this session. But of course, we need to provide guidance where there is limited research as well. And we saw this very much when the COVID-19 pandemic hit, for example, and there was this gap in global guidance, in WHO normative guidance in particular on hand hygiene outside of the healthcare setting. And, member states really
high demand for this guidance. And so for the last 4 years, we've been working on developing this global guidance. It's evidence-based to the extent that it can be. We commissioned a series of systematic reviews that were carried out by Emory University over the last few years. And for those of you who are interested in learning more about those, they're due to be published on the 16th of September. So do come and find me if you'd like to details on the launch of those and access to them. But those systematic reviews were comprehensive in nature. There are 5 of them, really covering everything from defining what we mean by effective hand hygiene, all the way through to what materials you need to have in place, what those minimum material requirements are, and looking at the behavioural aspects as well, seeking to understand much more systematically what are those drivers and those barriers to the practice of hand hygiene, what interventions might be effective at improving the practice of hand hygiene and making it sustainable, all the way through to government measures and what governments can do to really systematically improve sustained adoption of that behaviour. Obviously, you're asking me about climate change. There hasn't been a direct focus on climate change for these particular guidelines, but I would say that what we're trying to do is provide guidance for all settings where, in particular, there is a focus on, water-scarce regions, or providing guidance where supply chains might have been disrupted. So all aspects that might well have emerged from climatic events, but also from other events such as complex emergencies or other disruptions to resources and hand hygiene supplies. I think I just want to say that this point on what can we say with research and what can we say without, WHO has this very rigorous approach for developing guidance where there isn't evidence. And I just want to flag that for these 5 systematic reviews, there were a huge number of evidence gaps that we uncovered. And we find that we're not able to provide very specific information on what quantities of water are required for hand washing. And these are questions that do come to us from water-scarce regions and that will continue to come probably increasingly as we continue to experience the effects of climate change. So in the guidance that we published on the 15th of October, so Global Hand Washing Day, in about 6 weeks' time, you'll see that WHO has provided that guidance based on, as much as possible, the available evidence, but also on drawing on the expert opinion of a sort of purposefully curated group of experts from academic partners, including the very good Professor Robert Dreibelbis, but many others as well, and end users from a number of countries as well. So we hope that can be useful to help guide action whilst we continue working with the academic community to improve our understanding, not just of the specific nature of the impacts, like Lauren said, the descriptive side of things, but very much, I hope, moving also towards this interest in building more sustainable interventions that take account of climate change as well. So on that aspect of things, just to say we are planning now to move towards developing a future research agenda, specifically on hand hygiene, but of course that's connected to other hygiene behaviours. And I hope we can work together as this group continues to work on climate change and hygiene, because of course everything is deeply connected, and we need to make sure that we're not, even though we're shining a spotlight on something that has been neglected, climate change and hygiene, that we don't start to operate in silos and that we can look at the bigger picture as well.
Great. Thanks. And more blessings. I'm going to turn to you. We were talking a little bit earlier. I think cholera is kind of one of the kind of big diseases that we often associate with climate change, increases in severity, frequency, and some of your work with WaterAid's Pan-Africa program on kind of developing regional guidelines around cholera control. Can you talk a little bit about kind of how that relates to kind of what are the learning gaps, what are the evidence gaps that are kind of driving where you are in that process now? So.
Thank you, Robert. My name is More Blessings. I live in South Africa. I come from Zimbabwe. And Zimbabwe, Malawi, Zambia, Mozambique, every single year, especially around November, December, we know the rain is coming. Every single year, we have cholera outbreaks. And this is very directly linked to climate, and that there's more floods each year. The water and sanitation systems is contaminated, is destroyed. We know that that is coming, and I think Zambia last year had more than Zambia and Malawi and Mozambique more than 40,000 cases and almost like 1,000 deaths. And we see that coming every year, but we are not taking the relevant action. When that comes, there is a few interventions here and there, the government running around trying to put something together. January, February, March comes, the rain is gone, we go back to normal life. And we wait until the next rain season, which is quite sad. So anyway, that is the reality that I have to live with, and quite a few millions of people have to live with. So as water aid, we are saying what are the interventions that we can take. So there is the one part, that programming part that talked about, and I'm going to share a bit on the policy influencing side, because we realized that we actually needed to reach to our leaders to say, we have these situations, what can you as leaders do? We need to influence the right policies to be in place. We need to get the political will. Political commitment is a very, very big issue. WASH is not the sexiest issue, is not going to get the highest allocation for the budget. Probably defense and something else deemed more important is going to get that. And then we need the government to be creating the demand and supply for the services. So as water aid, we came together with WHO, actually, UNICEF, the SADC, which is the Southern Africa Development Community Secretariat, and World Vision, and said we need to do something. And then we developed the SADC regional hygiene strategy. And the point is to say to the SADC leaders, you need to come together as a region, as a regional bloc, and address this collectively. And we want them to make concerted effort, because we have very, very mobile populations, and you find that at the border areas, this is where the hotspots are. And people are literally like crossing like on foot. It's not like you're going to stop a whole aeroplane at an airport and say we need to fumigate everybody before they come off. These are people that are walking to their neighbors. So those areas are really like big hotspots. So this is why we say it shouldn't be a borderless issue. It shouldn't be a border. It should be a borderless issue, and that is why we came up with this strategy to say, let's come together as a region. Let's find a solution. And in that, like I said, the policies are a big issue, but also we realize that there are some policies that are already there on health, on education, on nutrition, and using those. How do we use those as opportunities to bring these issues in? So to an extent, we found that there was that policy environment that would be able to help us to get these issues going. And then one of the things actually that the strategy calls for is the need for more research, like everybody has been doing. You can never have more research. We need to understand the context that we are working. For example, there's no one size, even if it's in one country. You cannot have a one size fits all, even if it's in the same region. You need to understand by season, by month, by very, very important details that are usually overlooked, and then a solution that does not necessarily fit in comes, and of course we go back to the same season, same 20,000 cholera cases year in, year out. So we need to have more research to understand the challenges on the ground. But also I want to say, when we do this research, these policies and everything else, actions that we are doing, who are we doing it for? At the end of the day, it's about the woman and the girl. People, but I'll focus on the on the woman and the girl on the ground who have to walk longer distances because now there's no sanitation facilities and water facilities, who have to take care of the sick family members when the flood, when the cholera comes. So I think in all this research, I have not had the issue of bringing the most affected onto there. Usually they are on the periphery and they are more like subjects referred to. They can talk, we can come to the table to bring those researchers to life.
Great, yeah, powerful statements. Thank you very much. So now we kind of open it up to questions. So I think if there have been any online, Lauren will kind of flag those, but just general questions for any of our speakers, we can bring them up on stage quite quickly. It's a small room, so over to you. So, yep, go ahead.
Thank you so much, everyone, for the great presentations. I have a question for Professor. So you mentioned you are working with older people. So do you think the behavioral change is the main aspect for them in their life to deal with the climate change impacts? Maybe in their when they were young, they don't have to deal with what kind of challenges climate change impacts are bringing in the realms of hygiene, wash, and hygiene practices. For example, like, because I'm coming from Pakistan, if I think of my older generations, they didn't have a concept of drinking filtered water because they used to drink from running water streams. But now it's other way around, and we have to drink filtered water. We can't drink the water from running streams. So it's also very difficult for the older generations to think in that way, that it's now polluted. So did you come across behavioral change in that particular age is a challenge in terms of hygiene practices?
I've come across it a little bit anecdotally. It's not something we've really focused on very specifically in the study we're doing at the moment. The neighbourhoods we work in, most people continue to drink unfiltered water, and that water is generally unsafe because they can't afford, and that's people of all ages. In fact, I think what you see in terms of a change is that the younger generation are more likely to drink soda than water, which has its own consequences. And just to add one other thing about infectious pathogens in older people and hygiene and climate change, people tend to think about, things like cholera, quite rightly, but urinary tract infection, infected pressure sores for people who are bedbound. These are really important infections which are related to hygiene, which is related to climate change. And I think sometimes, again, they go under the radar. Thank you.
Oh, cool. Go ahead and stay up here. So I'll go over there. You pick.
You can go first. Thanks. Thanks for these interesting presentations. I have a question for Dr. Om Prasad. I hope I'm pronouncing your name right. Specifically about the results that you were showing. The difference between the baseline and end line was much bigger in Nepal than it was in Tanzania and Madagascar. And I'm wondering if you have any sort of explanations for this contextual variability, if there's certain interventions that work better in a Nepalese context versus the sub-Saharan African context. Thanks.
Operationally, there were two reasons. We actually looked at when the result actually came out. One, Nepal, the infrastructure that we built, then the intervention period, the cooling period was quite small when we started implementing it, just 1 month, because the other two countries, Madagascar and Tanzania, it was linked with also a cluster randomized trial with schools because their school intervention got delayed, therefore we had to push a little bit back. So what we have realized is if health workers are ingrained with so long, with the functionality of the facilities, resilient facility, all the time functioning, there is likelihood that they can sustain the behavior quite strongly. So, and then also the longer period of the functionality of those facilities. That was one reason. And second reason that we have looked, I think the contextual relevance of these activities, because of the standardization process for these all three countries, some of the activities that we have, the context relevance was more accurate to Nepal. I think some of the nudge intervention that we applied, for example, we use Buddha's eyes. Buddha is one of the, I mean, a god for Buddhism, for example. If you see these eyes, it's asking you to wash your hands, for example, right? The behavioral prompts and nudge was quite linked with the religious values and principle. I think that might have also resonated why that was successful. We have clustered all the learnings about the specific intervention ideas, whether nudge intervention or promotional ideas, and then we have also filtered them during the final analysis, like which one of those was more permanent and motivational, emotional, promotional for the people to actually adapt the behavior. So in the second phase of the intervention now is we are recommending to the government, we have listed all what has worked as a proof of concept and what need to be deleted from the package if you are going to implement further. So I think there were a couple of reasons why we thought might be, but we didn't then look specific activity-wise activity because it was in the trial, we didn't have the control group, so it's very difficult to say. It was the cumulative effect of the entire promotional and then also the WAS facilities intervention. Thank you.
We had one more question over there. But while the microphone is coming around, just give one nudge to all of our panelists. You can kind of see, hopefully, once you start reading these kind of research prioritized questions, this process, they get a little bit, we take a bunch of questions and we merge them together, and they get a little bit broad during this kind of process of synthesis. So I'd like to kind of just rapid fire around everyone that spoke today. What's the one burning question, or what's your one single priority question around this climate change, hygiene, and health nexus? It, doesn't have to align perfectly, but how does that, where are your key priorities that they can be as specific as you'd like? So start over there. Well, go with Chris's question first. So, oh, okay. No, it's just you go.
So my question was for Dr. Ohm, but also I think kind of for more general, whoever wants to respond. Your presentation about kind of baseline versus end line and how we typically think about measuring effectiveness of things is quite periodic. And I think what we have understood in the livelihoods and food production space is the importance of time series and designing research. And so I'm curious to hear from people from an experimental design perspective, how do we shape our research to better factor in climate so we can start to have these descriptive or developmental or kind of more design, we can start answering those. And so as a researcher, just curious to hear from whoever wants to answer, how can we do our research design differently? And one idea is do we focus more on time series type analyses and things? So that's kind of the gist of the question. Whoever wants to answer.
Katrina?
I'll pass to this, but responsive to the intervention that I mentioned, we were resilient since the beginning that there is a seasonality effect on the behavior because of the rainfall, the climate change pattern, and so forth. So we have done the baseline and inline exactly at the accurate time frame, May. Even baseline was done after the implementation of the infrastructure in May first year. Then the inline was done the next year, May, exactly the same time frame. So of course there are seasonality effect for the specific disease burden, but at the same time the rainfall pattern will also have the access to water, also the access to services, and also how the people behave, the way they have to be behaving. Also the other patterns, the socio-demographic statistics. I mean the characteristics can influence this. All of those were actually gathered and controlled during the baseline and inline. Of course, there are variations in terms of what kind of the methodology and study design that you can use, give you kind of more confidence and power on your study based on the methodological design. Since it was more on operational, we have used kind of simple before and after with seasonality variation actually accounted for during the analysis. I'm sure they will have more thought around that as well.
Cool. Thank you. Just kind of as a close, if we could get our panelists to respond to their kind of priority questions. I'm going to start over here with Katrina and run my mic over. So.
There are so many questions. I don't even know where to start with that one. I will just comment on that last point as well. So baseline and end line, I think we do have to be really careful that you can't account for any climate variability within that. And so even if you're using your baseline end line in the same season, what we saw as what was supposed to be hot and dry in Kenya was the better in terms of what. So, those things are not going to capture your climate variability. You do need some sort of continuous monitoring. Yeah.
How do we do it differently?
Yeah, and I think this is a different point. I could go on at length for how do we do evaluation for this in terms of the research priority. I think I'd be very, I think one of the things I don't understand is the longer term, the role between the impact of weather and on behaviour change and how that intersects with what we're seeing in WASH would be one area. Knowing that, for example, here in Sweden, I know it's salmonella season at the end of summer, and I expect there's a strong behavioural reason, so a link to that somehow. I don't know what it is, but trying to unpick those links so that we can better understand or project what's going to be the long-term issues.
I think from the operational point of view, WaterAid and also I think similar mandated organization will be very keen to understand what would motivate the government to replicate climate resilient behavior change intervention at a scale. I think what matters into the sector is the scale. We really would like to understand what are the driving factors for the government to do that.
Cool, thank you. Hand it over to our panelist. Yeah, go for it.
So I'm really interested in the fact that infrastructure and service delivery structures are really vulnerable to climate change, and we haven't worked out how to give people sustained access to sanitation and running water. And I would really like to know whether anything we do in the hygiene space is even sort of significant, or whether climate interactions on that are significant until we, the effect of broken infrastructure or no water drowns out everything else. So the relative importance is something we've really got to get our heads around, I think.
Joanna, more blessings? Yeah, go for it.
The villager in me is interested in how do we make people central to this? How do we make communities, the women, the girls, central to what we are doing, so that we can bring the right questions, bring the right answers, and make the right and effective plans for implementation so that we can address the problems. I can quickly share with you, we've done a piece of work in Mozambique on the national adaptation plans, and we had teams that went and sat for weeks with women in the villages, speaking to them in their languages, understanding what they want to bring, and we believe that the more we do that kind of detailed researches and gathering information, we can come up with solutions that are more appropriate and relevant.
Thank you. Joe?
Thanks. Yeah, just to echo what Barbara said, I think it really is key for us to focus on infrastructure. I think it's very difficult to do any of the behavioural side without that infrastructure, let alone then focusing on what Katrina said about how behaviours then change based on climatic changes as well. So I'd be interested in that, and specifically in more research, operational research, to understand what government measures can actually move the dial in terms of infrastructure and how we can implement those so that we avoid the panic and neglect cycle that More Blessings talked about, and which we see as well in the context of pandemics and other health emergencies. How do we make hygiene more of a priority within governments and really measure change?
Cool. And then we will end with Peter. So.
Oh, thank you. Yeah, a Brazilian statty friend of mine was doing some analysis looking at the risk of dying if you're old, and he found in the northeast of Brazil, older people had a lower risk of dying in the summer months 10 years ago than the rest of the year. Over the last 3 years, the risk of dying has been double in the summer months compared to the rest of the year, and that's clearly a climate change effect. So my question would be, what role does hygiene play in that? I think there are a number of reasons why that has occurred, but I think hygiene is a big part of it, and I would like to know more. Thank you.
Cool. Well, thank you, everyone. We are at time. Big hand to all of our panelists and all of our speakers. So thanks. We were hoping to have this prioritization exercise. It's sitting with a preprint server right now. So Google it in a couple of days and you will be able to read all of that. But yeah, thank you very much for joining. So.